this is the end of my early stage. What do you think? Shall we take the questions now, or shall we keep it at the end?
Should we do them now while it's fresh in our
Yeah,
head?
of course,
Because very interesting talks, and thank you so much for such a thorough review of all these interesting trials, and hopefully, yeah, some of them would be practice changing. So, firstly, let's start with a question that was posted. The question has been posted by Dr. Iftikhar, and he's asking that if after receiving neoadjuvant chemo with a triplet, and then undergoing surgery, the histology indicates progression, but it is completely resected. Would we still recommend adjuvant systemic treatment?
it's very rare that the histology will only show progression, because your scans will pick up the progression
Exactly. Yeah.
earlier before you even go to the resection.
Yeah,
So
and I guess you wouldn't call it progression. You would probably say that that was the true staging, because sometimes radiologically the staging is not completely, is not a true representative of the complete disease, whereas the pathological staging is always the true staging that you get. But I guess this needs to be dealt by case, and if the overall stage does have, if it's a high stage, if the nodal status is high, then yes, I think we should recommend systemic adjuvant treatment. That's my take on it. But Talha, what do you think?
yeah, I completely agree with you, Noor, but I think the only difference that will come is it will be picked radiologically. Surgeon,
Exactly. Yeah.
when
Exactly. It should be. Yeah.
sitting in the
Mm,
MDT, surgeons
mm.
clearly say that
Yeah.
if it is progressing
And
clinically, they will not resect it. Let's say if it gets resected and then comes back quickly within a month or so, I
yeah.
think that poses more problem as
Yeah.
compared to if you find it post-surgically, because you have used your immunotherapy. That
Yeah.
means whatever triplet you have used, irrespective of the type of immunotherapy you have used,
Yeah.
not working. So this
Exactly.
patient, yeah,
Yeah.
patient
Yeah.
is
So
a
these, yeah.
higher.
Yeah. So these patients are
Actually, this was one
sadly.
of my patients. Hello.
Oh, I see. So what
Hi.
happened? Can you tell us? Was
Yeah,
it picked up
yes.
radiologically?
No, it was not picked up radiologically. So,
Uh-huh.
but on the pathological specimen, it showed progression.
Oh, I see.
So,
Mm.
but I was actually confused. My consultant, eventually, I can recall, she had discussed that thing with a couple of people, and she said that we would not consider adjuvant systemic therapy. There is no evidence for that. But to be honest, at that moment, I also had the same impression that we should have given adjuvant systemic therapy, and even I documented that that my understanding is that adjuvant systemic therapy is given, but my
But
consultant does not want.
what was the pathological stage, Dr. Iftikhar? The eventual.
Uh, it was, I think, I can't recall at the moment.
That's
It was
fine.
like
Don't worry.
4 or 5 months ago, but
Yeah.
it was definitely, I mean, upstaged on surgery.
Yeah.
But
Yeah.
it was
Yeah.
not, there was not radiological progression, but it was upstaged
Mm.
on surgery.
I think,
Okay. Yeah.
Jandev, this should have been one of the classical
Mm.
patients where ctDNA
Mm.
should have guided a lot.
Yes, I was just going
Yeah.
to. Yeah, ctDNA would have helped.
It should have been one of
Another.
the.
Yeah. Yeah, another question by Dr. Khan. If there is no pathological complete response post neoadjuvant treatment, but less than 5% viable tumor, would you still advise for adjuvant treatment? So this is, I guess, a case of major pathological response, but not complete. Yeah.
Yes, yeah. We have seen that if it depends upon which trial protocol you have used. If you have used
Mm.
only the new adjuvant arm, then you can decide upon the adjuvant whether you want to give or not. But if you
Mm.
have used the perioperative arm, I would still go with the perioperative immunotherapy of completion of 1 year, whichever immunotherapy you have used, because we have seen in the trial that the perioperative treatment, like the pathological complete response and the major pathological response, they do translate into event-free survival. But continuation of immunotherapy in the perioperative setting also does the same thing. So it's good thing that you have got a pathological response or near a pathological complete response, but I will be in favor of still at least continuing with the immunotherapy. Chemotherapy is a plus minus. I will not favor probably that.
Okay, yeah. Another question. If someone is KRAS mutant, shall we offer neoadjuvant Nivo? Why not? I don't think being KRAS mutant sort of, excludes you. But sorry, were you thinking about the people who have STK11, KEAP1, and SMARCA4 mutations? Is that what you were worrying about in terms of resistance?
Yeah, I think the thing we need to understand is that these markers are prognostic at the moment. They're not.
Yes, and it's very early days, and so I guess going forward, Dr. Hafiz, I feel that maybe a day will come when you would stratify patients who have these markers, and then you would choose to give them ipi/nivo. Obviously, once NICE lets us do that. But a very interesting discussion. The only other thing I found very interesting was that in the Checkmate trial, they looked at less than 4 cycles, because that's, in real world data, that is a very sort of, real problem that you see patients occasionally with less than, whatever the recommended trial. And it's very, very good to have that data and very helpful. The only other question I was thinking about, or maybe a comment really, is that going forward in future, would we be treating people who have ctDNA clearance differently, at the end of the neoadjuvant treatment as compared to the ones who don't?
Yeah, I think it's the problem with the ctDNA will be how you assess it and how deep you want the ctDNA to be negative, like an MRD. If you're looking for a minimum residual disease or something like that, the most important question, like this was raised at one of the conferences recently, and if we look into it, the answer was we need at least 5 years to completely
exactly. The data is
on the
you don't have
ctDNA.
complete.
I think it's quite early, but it's very interesting. Like
absolutely, very interesting, and
like with Jahangir,
very intriguing.
The patient which he presented, I think in that case, if we have the ctDNA, I know there is funding restriction.
That would have helped. Especially if the ctDNA was increasing as we were treating. Another $1 million question posted by Dr. Butt. Is there a difference or a favorable immunotherapy amongst Pembro, Tizo, and Nivo? I guess still we have a trial comparing all of those, which we can't say. But what do you think, Dr. Hafiz?
I think I would love to agree with you, because there are different companies. There's a different companies.
Exactly.
They will never do a head-to-head trial.
Yes. Until we have head-to-head trials, we can't.
This is South Street. I'm not sure about Copper Street, whether Copper Street.
Sorry, I think somebody was.
Plus, we cannot cross-compare the trial because we don't know which trial has more patient population who was
absolutely. You can't.
I would say physician discretion, whichever they are.
But one day, maybe in future, one day we will get a head-to-head trial. Okay, I guess let's move on to Dr. Batul now. So she's one of our clinical oncology trainees, eminent in her career, in the sense that she is working as an oncology representative with RCR. She's also on the National Leadership Forum, and she presented a very amazing poster in ESMO on sotorasib, which really looked at the real world data. So the sort of knowledge and data we are very interested in. So without further ado, Dr. Batul, over to you. So if you can start with your presentation now. And before you start, if you can tell us if you've got any declarations of interest, please. Thank you, Dr. Batul.
Hi, everyone. Thank you. Thank you, Dr. Hafiz, for this brilliant presentation. Thank you, Dr. Bird, for giving me an opportunity to present today. My name is Rubab, and I'm ST5 Clinical Oncology Registrar at Oxford University Hospital. I've done part of my training in Birmingham, and now I've been transferred to Oxford. I have nothing to declare, so that's why I haven't added a slide.
Thank you. Can you please change to the slideshow?
Yeah, I am trying to do that. Can you see this now?
Yes, much better now. Thank you.
Give me 1 second. I'm just going to try to, Give me 1 second. I'm just trying to kind of change the screen settings. Okay. So today I will be discussing immunotherapy trials around immunotherapy combinations and targeted agents and in non-small cell lung cancer, metastatic and locally advanced setting, and then a bit of a slide on small cell lung cancer extensive stage. So to begin with, in the immunotherapy space, we have Galaxy's 201 trial. It's a trial looking at the belrestotug, which is an anti-TIGIT antibody in combination with dostarlimab in patients with previously untreated locally advanced metastatic PD-L1 positive non-small cell lung cancer. A bit about belrestotug. It's an anti-TIGIT antibody. So the concept here is that TIGIT antibodies are the antibodies that bind to the inhibitory receptors and lead to the suppression of the immune system. So blocking the TIGIT with the anti-TIGIT enhances the immune system. And dostarlimab is an anti-PD-1 antibody comparable. Its clinical activity, as demonstrated in PERLA trial, is comparable with pembrolizumab. In terms of study design, the patient cohort was previously untreated, unresectable, locally advanced metastatic non-small cell lung cancer. They were randomized to either receiving dostarlimab or three different doses of belrestotug, 100, 400, and 1,000 milligram. The primary endpoint was overall response rate. And this was a small study that they took 124 patients on board. In terms of the baseline demographics and disease characteristics, the ECOG performance status were slightly better in belrestotug and dostarlimab combination group as compared to the dostarlimab alone. And primary efficacy-wise, as we see, there is an improvement in the overall response rate, regardless of the belrestotug in the combination group, and they were significant. They were significantly high in the high dose belrestotug 1,000 milligram and dostarlimab group. And as you can see, this is a water plot slide, and there are quite good deep responses in the water plot. Partial response are the green lines, and we can see there are quite a good number of deep partial responses. Safety profile wise, this all comes with a safety profile. Serious treatment related adverse events are 3% in dostarlimab and belrestotug group, progressing in the combo group, and 11% in the highest dose group. And hence the discontinuation rate also going up as we go along the belrestotug dostarlimab dose high groups. Most of the adverse events were skin pruritus, immune-mediated hypothyroidism, ALT, and pneumonitis and myocarditis. Investigators said they were quite manageable, but there were some grade 3 toxicities in the highest dose group with myocarditis and pneumonitis. So conclusion-wise, it was a clinically meaningful improvement in ORR was observed in all the combination cohorts versus dostarlimab alone. Combination regime had an increase in immune-related adverse events, which were manageable. Additional follow-up of the trial will better characterize the long-term efficacy and safety. And now there's an ongoing recruitment to Galaxy's 301 phase 3 study of belrestotug and dostarlimab versus standard of care pembro. And these are just my thoughts on this trial, that we need more efficacious first-line combinations to improve response rate and durability of response as we see with the standard of care. Here I have, in the second point, I have just compared the Keynote 024 trial with the Galaxy's 201 trial. As you see, the overall response rate is better in the Galaxy's Lung 201 trial, but the toxicity discontinuation is slightly better in the Keynote 024 trial. And we need to wait now for phase 3 data about toxicities and durability of response, and whether toxicities will have any impact on the quality of life and hence compliance. in the second space, in the immunotherapy space, the second trial we have is a Relativity 104 trial. It's a negative trial, but I thought it's good to mention the negative trials as well. So it's a combination of Nivo and platinum doublet with the relatlimab, which is a LAG-3 inhibitor, comparing with the Nivo and platinum doublet. So here the concept is the LAG-3 antibodies suppresses the immune system. So if we block the LAG-3 with the anti-LAG-3, then this results in the boosting of the immune system by restoring the effector T cell function. And it's the first randomized phase 2 study on the LAG inhibitors. Talking about the study design, the key eligibility criteria was recurrent non-small cell lung cancer and no targetable mutations. They were randomized to either receiving Nivo plus chemo or Nivo plus chemo or relatlimab. They were further pre-stratified by tumor PD1 levels by more than 1 or less than 1, histology-wise non-squamous cell versus squamous cell, and performance status-wise as well. The primary response rate and primary endpoint was overall response rate. Here in the baseline characteristics, as you can see, the groups were well matched and there was not much differences. Now here the graph, when we look at the overall response rate and the PFS of 6.7% versus 6%, it was actually a negative study, despite there is a bit of a 7.6% difference in ORR. There wasn't much of a difference in combination arm versus the standard arm, which was at the moment chemo and Nivo doublets. So they went on to do the subgroup analysis, and there was a definite benefit in the group of the patients with PD-L1 more than 1% at 6.1%, 6.1 versus 9.8 versus 6.1. And there was no difference in squamous versus non-squamous histology. And in terms of a further analysis on PD-L1 expression of patients more than 1% in non-squamous cell cancer, there was a statistically significant increase in PFS in the chemo, Nivo, and relatlimab group at 11.6%. And if we further split them into according to their PD-L1 levels, then from these graphs, we can clearly see that the patients who had major benefit were having PD-L expression from 1 to 49%, with the levels with the PFS of 9.8% versus 5.6%. Toxicity-wise, there were no additional toxicities, and the toxicities were quite manageable, and they were related to what we normally see with the patients in immunotherapy group. Conclusion-wise, it was a negative trial in all first-line recurrent or metastatic non-small cell lung cancer. Sorry. Benefits were seen in PD-L1 positive population where PD-L1 was more than 1%. No difference between histology, and largest benefit in PD-L1 from 1 to 49% with overall response rate of 60% and PFS of 9.8 months. But in this study, the number of patients were small. And Relativity 1093 is an open label randomized phase 3 study evaluating Nivo plus relatlimab plus platinum doublet chemo versus standard of care, which is Pembro and platinum doublet at the moment, for patients with metastatic non-small cell lung cancer, where PD-L expression is 1 to 49% and non-squamous cell histology. My thoughts are we need more efficacious first-line combination, and at the current standard of care Keynote 189 pembrolizumab, in that study we have overall response rate of 49% and median PFS is 8.8 months. Early phase 2 data of relativity is a little bit promising, but we need more phase 3 data. And as we know, phase 3 could be negative despite promising phase 2 data. And we need to integrate subgroup analysis in the pre-planned or in the trial design, as repeated subgroup analysis in a smaller trial population could lead to misleading results.
नीचे से वो लेके आओ, मैं इधर खड़ी होती हूँ, मेरे साथ जल्दी से डाल के कर लो.
Sorry, let me just mute who is.
I have done
I
that.
don't know who that is.
Thank you. Thank you, Tala. Thank you. So in targeted therapy space, we have Crystal 12 trial where they compared adagrasib versus docetaxel in patients with KRAS G12C mutated advanced non-small cell lung cancer and patients with the brain mets as baseline brain mets as well. Sorry. This was the study design where the patient population cohort was locally advanced metastatic non-small cell lung cancer with KRAS G12C mutation. They were prior treated with platinum doublet and anti-PD-1 therapy, and neurologically stable brain mets were allowed to enter the study. They were randomized either to receiving adagrasib, 600 milligram BD, or docetaxel. Those who had brain mets were required to have the brain imaging at the baseline. And primary endpoint was progression-free survival. Baseline characteristics-wise, patients receiving adagrasib had a better performance status than those who were receiving docetaxel. And patients, if you look at the systemic efficacy graph, the median progression-free survival was better in patients who were receiving adagrasib as compared to docetaxel. And if we compare the patients with brain mets and without brain mets, then the PFS was better in patients without brain mets who were receiving adagrasib. Safety-wise, tolerability of targeted agents remain an issue, leading to dose interruptions, serious treatment-related adverse events, and discontinuation as well as compared to the chemo arm. And conclusion-wise, adagrasib demonstrated improved intracranial efficacy versus docetaxel in patients with treated neurologically stable baseline brain mets. Or overall response rate, progression-free survival, and durability of response were greater with adagrasib versus docetaxel, and safety profile of adagrasib and docetaxel. It wasn't really consistent, but the patient tolerability remains an issue with the TKIs. And adagrasib is an efficacious treatment option for patients, including those with the brain mets with previously treated KRAS G12C mutated non-small cell lung cancers. My thoughts are it's a good option in previously treated KRAS mutated patients. We need more combination/targeted therapies for sustained response in the first line. Median PFS of 4 months versus 2.9 months in patients with brain mets, and tolerability of these agents remain an issue in the clinical practice. Now, talking about in EGFR exon 20 insertion mutation space, we have zipalertinib in non-small cell lung setting in patients who received prior amivantamab. So in it was a resilient phase 2b trial. Talking about the study design, zipalertinib is an irreversible TKI. It was studied in a setting where patients were progressed on or after amivantamab, who had EGFR exon 20 insertion mutations, and stable brain metastasis patients were allowed to enter the study. They received zipalertinib 100 milligram BD. Primary endpoint was overall response rate and durability of response. 30 patients were response evaluable. In UK, actually, we use chemo in the first line as NICE did not recommend it amivantamab, whereas in other countries, we do have access, people do have access to it. So that's why I thought to discuss this trial.
बाकी तुम लोगों को हाँ जो जैसे मुर्तजीज है.
Sorry, thank you. Talking about the baseline characteristics in the demographic data, patients mostly received amivantamab, but small number also received amivantamab and other TKIs like osimertinib. And most of the patients also received prior chemotherapy, as we can see here, and the brain mets people were also allowed to enter the study. And overall response rate wise, we have 50% response in amivantamab only patient in the group, the patients who received amivantamab only prior, and disease control rate was 89% around, and median progression-free survival was 9.7 months. In terms of safety, treatment-related adverse events, the side effects were related to what we normally see in the clinic with for patients on TKIs, but there were some grade 3 serious adverse events leading to the dose discontinuation. So conclusion-wise, as the zipalertinib as an irreversible and selective exon 20 insertion TKI, mutation TKI, zipalertinib demonstrated promising efficacy in patients progressed on or after amivantamab, overall response rate of 40% and PFS of 9.97 months. Well tolerated and demonstrated a manageable safety profile. CNS data is yet to be published. My thoughts are amivantamab. I think if I'm not wrong, NICE is meeting next year to see to make a decision about amivantamab. Irreversible TKIs like zipalertinib could be an option post amivantamab. Phase 3 trial, we need more phase 3 trials looking at TKIs and versus chemo combinations. And there are a few phase 3 trials that I picked that came up when I was doing literature search was Resilient, Wukong, and Fovent, and they were looking at the combination. They're looking at the TKIs versus chemo. Now, in the ROS1 fusion positive space, we have a phase 1/2 ARROW study, which was studying zidesamtinib in ROS1 fusion positive solid tumors. So in terms of the patient population, in terms of the study population, in terms of the zidesamtinib, the names are getting difficult with every trial coming up. So it was a phase 1-2 clinical trial, and this molecule has demonstrated ROS1 activity, ROS1 mutant activity, brain penetrance, and it has shown activity against the compound mutations, which are posing a problem in the clinical setting. In terms of the patient population wise, again, here patients were heavily treated with the ROS1, anti-ROS1 TKIs. Most of them received 3 or more TKIs. In terms of the graph, this graph I would like to discuss first. So here, if we look at the previous patients who received previous TKIs, the response rate is around 44%, whereas patients who have not received prior TKIs, the response rate is 72%. CNS activity, in terms of CNS activity, durable CNS response, and this molecule has a good CNS penetrating capacity as well. Good safety profile, and there were not any adverse related events. Small events were manageable as per investigators. Conclusion-wise, durable response observed in heavily pre-treated population across subgroups of patients, good safety profile, durable intracranial response. And my thoughts are it's an encouraging data, good safety profile, and durable intracranial response. So could we use this probably at the first line? But time will tell, and we need more data. And now in the ALK positive space, I'm going to discuss phase 1-2 ALK study, which was discussing molecule NVL-655. It's a new 4th generation ALK inhibitor, has a good CNS penetrability, and this has shown activity against the compound mutations as well, which we are seeing in the clinic and has been causing a problem. Again, it was a heavily treated population, majority have been exposed to previous ALK inhibitors TKIs. Preliminary activity-wise, any ALK mutation who were receiving recommended phase 2 trial, phase 2 recommended dose, the response rate was 55%. And in G1202R mutation, in our recommended phase 2 trial, recommended phase 2 dose, the response was 71%. Patients progressing on lorlatinib, the response rate was 50%, but in the mutation group, it was 64%. Durable intracranial response, durable response, especially if they are previously lorlatinib naive. Good CNS activity. And safety-wise, it's a favorable. Dose reductions happened in 15% of the patients due to treatment-related adverse events, and 2% had discontinuation due to treatment-related adverse events. Conclusion-wise, the small NVL-655 molecule is a fourth-generation ALK-selective brain-penetrant and TRK-sparing TKI, durable responses, and durable intracranial responses as well. So my thoughts are good option post previous platinum doublet on TKIs. Could it be a new standard of care? And do we need more head-to-head trial comparison with the current standard of care? Probably. And though this study was discussed in detail at ESMO last year, but I just thought to add 2 slides on Mariposa study, just because it was discussed, the extended results were discussed in 2023 this year as well. So in this study design, the key eligibility criteria was locally advanced metastatic non-small cell lung cancer. They were randomized to receiving amivantamab or lazertinib, osimertinib or lazertinib. Conclusion-wise, there wasn't significant differences. No significant differences were observed among MET and EGFR independent resistant mechanisms. Amivantamab and lazertinib had a low rate of TP53RB1 loss associated SCLC transformation, and osimertinib had a higher frequency of complex resistance than amivantamab and lazertinib. Now, in extensive stage small cell lung cancer, there wasn't much discussed in ESMO this year, but I just thought to touch upon this upcoming antibody kind of trial, which is still in phase 1 trial, and it's BMS 986012 called antifucosyl monocyaloganglioside 1, which they were giving with carboplatin, etope, and nivo as a first-line therapy in extensive stage small cell lung cancer. The concept behind this is anti-FUC-GM antibodies are richly expressed in most small cell lung cancer tumors. So if we can block this by some monoclonal antibodies, then this would reduce the cell death. And as per the investigators, the BMS 986012 is a non-fucosylated, first-in-class, fully human IG1 monoclonal antibody. This was a study design. This was a study design where they were randomized to receive either BMS, the small new immunoglobulin, plus nivo plus chemo, and the other, or whether they were receiving nivo plus chemo. And then after the maintenance were this BMS 986012 and immunoglobulin plus nivo. And interim analysis showed modest response with the addition of anti-FUC-GM, safety profile almost similar to that of nivo plus chemo, and we need more phase 3 data to confirm these findings. That was a poster which we presented at ESMO. It was looking at the real-world outcomes and tolerability in patients with advanced non-small cell lung cancer treated with sotorasib in the UK. We had 125 patients, which were equivalent to a phase 3 trial of the CodeBreak 100 trial, and our results were comparable with the CodeBreak 100 trial. And these are my acknowledgements, and happy to take any questions if there are any.
Thank you, Rubab. That was an amazing overview of all the latest trials. So any questions? I guess somebody was asking about aventinib, whether it is being whether it's available in NICE, but I guess I think you just clarified that in the next slide that NICE is going to review that in April 2025. And I guess Dr. Butt wanted Dr. Talhafiz to go through the LAURA study. So, or, if there's any other questions anyone has, you can let us know. But great poster, well done on that. And thank you so much for your overview.
Thank you.
Right. What are the options in exon 20 insertion at the moment?
Sorry, are you asking me at the moment?
So that's one of the questions that's been posted.
I can't see the chat actually.
You have to click on chat.
The options are very limited, to be very honest.
Yeah,
this is one of the resistant disease which you will find, unfortunately. They don't respond to the normally available TKIs. I would say if you have amivantamab available, then that might be an option in combination with the standard chemotherapy. If not, then I would prefer chemotherapy rather than any TKIs. There was some availability of mobocertinib earlier, but later interim analysis did not prove any survival advantage, so it has been withdrawn.
Yeah.
And excellent presentation, Rubab. Yeah, and the
Thank
poster.
you so much. Thank you, and thank you so much for contributing to our poster, Dr. Hafiz and Dr. Raza as well.
I think Ali is on the call, but he's quite mute at the moment. Just a few things about what WhatsApp has asked about the LAURA trial. So it was presented basically, I think, at ASCO, published in Najm in June this year. It was for stage 3 unresectable EGFR mutant lung cancer, who after chemoradiotherapy were randomized to osimertinib maintenance or placebo indefinitely. And the analysis was remarkable because the hazard ratio was around 0.16, significant improvement in the progression-free survival. I think it was around 38 or 39 months versus 5.6 months with the placebo. So I think it has been approved by the FDA. NICE is currently looking at it, might be available by early next year. The only thing which we need to be careful of will be, in terms of management, will be after the chemoradiotherapy, the risk of pneumonitis, especially if you give osimertinib, will be high. I think even in the trial, there was around 30 or 38% risk of pneumonitis post-treatment. It depends on the grade, of course. Majority were grade 1 and grade 2, but still, if you get a grade 3, then you might have to discontinue the treatment. But it was presented a bit earlier than ESMO, so we didn't include it in the presentation today.
Thank you, Dr. Talhafiz. That's very useful.
Dr. Butt is there. We can have his remarks if there is no other question.
Sure. Looks like there is no more question. Thank you, everybody, for contributing, presenters in particular, and thanks for sharing as well.
Assalamu alaikum, Dr. Butt. Just Dr. Zafar is here from Castle Hill Hospital.
Go ahead, Zafar.
So thank you so much for this nice presentation for all my colleagues, and that's the first all. So just 2 updates. Maybe most of our lung colleagues, especially, they know about that. One of the alectinib now is coming already approved by NICE as an adjuvant now. If you remember, the osimertinib already is there, but for ALK positive patient now, alectinib is a part of NICE guideline, and you can use in any adjuvant setting furthermore. But criteria is only the tumor size supposed to be 3 centimeter, and then
I think for Alina it was 4 centimeter, if I'm not wrong. But
for alectinib, 4 centimeter, osimertinib is a 3 centimeter actually. Yeah. This is what we're thinking because they are changing. Anyway, so this one and another update is there because they add also new adjuvant setting for pembrolizumab actually. So now the pembrolizumab also adding on adjuvant setting. It is actually new adjuvant chemo pembro, and then after adjuvant, the pembrolizumab will be add on, and there's no need for PD-L1. Even before atezolizumab is there, more than 50% PD-L1 in adjuvant setting. For pembrolizumab is above 1% is okay for that. That's 2 updates now. We are adding in NICE already.
Okay,
Thank you,
great.
Mustafa. That's very useful updates for people like myself who are sitting in the periphery. So
Yeah.
thanks for that update.
Thanks. Sir.
So thank you again for speakers, moderator, chair, and clearly contributors and people who have joined from various parts of the world. Dr. Ali has already put a little note about the feedback forms. So please click the link, and then if you can get feedback about today's presentation. Unfortunately, earlier on, we could not record Dr. Hafiz's part of the conversation, but hopefully he'll re-record it, and we'll have 2 different YouTube links sent over in the next couple of days for people to listen to the recordings. And next Saturday is a possibility that we may not be able to do a presentation because my speaker unfortunately had a major health issue and she has pulled it out. We were going to do melanoma. So if I find a speaker in the next few days, I may send an invite. Otherwise, we'll see you again on Saturday, 2nd of November with urological cancer updates. And following that will be GI updates, the next 2.
Dr. Robert, Uzaid was on call. Uzaid is doing melanoma with me for a year. If he is willing to do a presentation next week, we can do it.
Absolutely fine with me. It's just my speaker had myocardial infarction, unfortunately. So I just didn't ask her to do it. So if Uzaid can do it, it'll be lovely so that we can continue our weekly presentations. So
I will
that's.
I will drop you a message.
Yeah. Thank you. And we will hopefully people who did send email last week, and anybody who's clearly outside UK, we don't have your email. Send the email on the info that bpca.uk.info page, and I'll send the certificate. Hopefully, that this is from this week onwards. I just came back from Pakistan this morning, so I'll be doing more work. Hopefully, BBC later work in the next few days, and you will all get your certificate of participation, which you can use for your CPD points.
Thank you so much, sir.
Thank you so much, Dr. Bhatt.
Thank you very much, everybody. We'll see you next week or week after.
Office.
Thank you. Thanks, everyone.
Thank you.